So, I want you to imagine an organ, but not just a standard run-of-the-mill organ. Imagine one that manufactures chemical payloads so intensely caustic, so, like, highly destructive, that if its internal plumbing fails by even a fraction of a millimeter, it will actually begin to literally digest itself.
Right, and not just itself, it'll digest the surrounding internal organs from the inside out.
Exactly. It's terrifying. And today we are diving deep into the human pancreas. And if you are listening to this right now, you are essentially stepping into the surgical theater.
Yeah, we are specifically tailoring this deep dive for the high-level learner. So, you might be a surgical candidate prepping for your FRCS exams, or maybe a PhD researcher in clinical anatomy.
Or just a clinician trying to make sense of some incredibly complex retroperitoneal pathology. Because we are pulling heavily from rigorous Stat Pearl's NCBI bookshelf source material today.
We are, to really map out the embryology, the microscopic architecture, and the high-stakes surgical topography of this hidden volatile organ.
Yeah, and you've called it the ultimate high-wire act of human biology before, which I love, because most anatomical structures, they give you a clear, visible blueprint. Like a femur is obviously a mechanical pillar, right?
Right.
And the heart is clearly a fluid pump. You look at them, and their form perfectly dictates their function in a very clean, walled-off sort of way.
Absolutely. But when you step into the retroperitoneum, that space deep in the back of the abdominal cavity, all of that clean engineering just completely vanishes.
It's just chaos.
It really is. The pancreas is an organ defined by developmental chaos. It has to navigate one of the most hazardous, densely packed anatomical neighborhoods in the human body.
So true.
And to understand how to operate on it, or even how to diagnose a cryptic pancreatic disease, you can't just memorize what the organ looks like in its final state. You have to understand the exact perilous journey it took to get there.
Which means we need to rewind the clock. All the way back to 4 weeks of human gestation. Right. So at 4 weeks, your entire gastrointestinal tract is essentially just this primitive, undifferentiated tube of endoderm, right? The innermost layer of cells in the embryo. You've got a foregut, a midgut, and a hindgut.
Yes.
And the pancreas, it doesn't just grow as a single cohesive unit. It's not like an apple budding on a branch. It actually begins as two completely separate, independent outpouchings from that foregut endoderm.
Yeah, the dorsal bud and the ventral bud.
Yeah.
And honestly, that is the defining structural quirk that sets up literally all future pathology we see.
How so?
Well, at 4 weeks, these two buds are growing out of entirely different sides of the developing gut tube. The dorsal bud pushes outward into the dorsal mesentery, which is the connective tissue at the back of the embryo.
Okay, so it's heading backward.
Right. Meanwhile, the ventral bud emerges closer to the front. It's right alongside the newly forming hepatic diverticulum.
Which is the tissue that eventually becomes the liver and the gallbladder, right?
Exactly. So they are completely physically separated by the gut tube itself.
And this is where the spatial choreography gets incredibly complex. So at 4 weeks, they form. But as we move into the 6th week of gestation, that ventral bud, the one near the developing liver, does something really extraordinary.
It migrates.
It literally migrates. It begins to rotate around the right side of the developing duodenum, and it is a slow, agonizingly precise migration, because it isn't until, the 17th week of gestation that this traveling ventral bud finally swings all the way around to the back.
Yeah, week 17. It finally meets the stationary dorsal bud, and only then do they fuse together to form the single macroscopic organ we'd recognize in an adult.
Wait, I mean, if I can just play devil's advocate here, that seems like a massive evolutionary flaw. Why force the ventral bud to migrate across the abdominal cavity for 6 weeks?
Does seem crazy, doesn't it?
Yeah. Why not just have both buds develop in place on the exact same side of the gut tube from day one? It seems like an unnecessary high-risk maneuver to have half of a vital organ traveling through a developing abdomen.
Well, it looks like a flaw until you look at the surrounding real estate. The foregut during weeks 4 through 6 is undergoing massive, violent expansion. The stomach isn't just growing, it's undergoing this complex 90-degree longitudinal rotation, plus an anteroposterior rotation.
Yeah, wow. So everything is just shifting and turning.
Exactly. And at the exact same time, the liver is experiencing explosive, rapid growth. It's taking up massive amounts of space in the right upper quadrant. So because the liver and stomach are expanding so aggressively, the primitive duodenum is physically forced and contorted into its characteristic C shape.
Ah, okay. So the ventral bud is essentially just getting dragged along for the ride.
Precisely. The ventral bud is tethered to the bile duct system. So as the duodenum rotates to the right to accommodate the massive stomach and liver, the ventral bud is carried along with it. It swings structurally behind the duodenum.
So it's not a flaw, it's a spatial accommodation.
Yes. It's an evolutionary space-saving mechanism. This migration ultimately parks the mature, fused gland perfectly into its retroperitoneal sanctuary, tucked away safely behind the stomach where it's protected from direct trauma.
Okay, that makes sense. But the fusion at week 17, it isn't just about the physical tissue mashing together, right? It's about the internal plumbing.
Oh, the plumbing is everything.
Because when these two distinct buds fuse, their internal drainage networks, these tiny ducts carrying those highly destructive caustic enzymes, they also have to splice together flawlessly.
Right, and they have very specific jobs. The dorsal bud, which, remember, stayed put, is responsible for forming the vast majority of the final organs. So that's the upper portion of the pancreatic head, the entire body, and the tail.
And the ventral bud, the traveler.
It forms the lower portion of the head and a very specific hook-like structure called the uncinate process, which wraps around major blood vessels. And originally, both of these buds had their own independent ducts draining into the duodenum.
You know, the analogy I keep returning to is that it's like hiring two highly specialized, completely independent construction crews, and you tell them to build different halves of a vital chemical manufacturing plant.
That's a great way to look at it.
But they aren't building them next to each other. One crew has to execute this incredibly complex spatial rotation, literally dragging their half of the factory across the site just to slam it into the other half at week 17.
And when they hit, they have to align their high-pressure internal piping systems perfectly, down to the millimeter.
Yeah, and we know the specific names of those pipes, which is important because they dictate surgical approaches for FRCS candidates.
Definitely. When they fuse, the duct from the ventral bud splices with the distal part of the dorsal duct. Together, they form the main pancreatic duct, which is clinically known as the duct of Wirsung.
The duct of Wirsung. So that's the primary highway for the massive volume of pancreatic enzymes.
Exactly. However, the proximal part of the original dorsal duct usually persists as well. It forms the minor accessory duct, known as the duct of Santorini. And that empties into the duodenum just slightly above the main duct.
Which brings us to what happens when this 17-week fusion fails. Because this embryological dance is so protracted and so complex, the slightest microscopic misalignment leads to a cascade of structural variations.
And if you are a surgeon or a gastroenterologist, you have to be acutely aware of these variants, starting with the most common developmental anomaly, pancreas divisum.
Right, pancreas divisum.
Divisum occurs when that vital week 17 fusion of the ductal systems simply does not happen. The tissues of the dorsal and ventral buds might physically touch, but the plumbing never splices.
And the Stat Pearls text says we see this in roughly 10 to 15% of the general population.
Yes, it is an incredibly common anatomical variant.
I mean, 10 to 15% is a staggering number, and the mechanical consequence of that is the entire tail, the body, and the anterior part of the head of the pancreas, which is the vast majority of the organ's exocrine output, is forced to drain all of its highly concentrated enzymes through that tiny minor accessory duct, the duct of Santorini.
Right. And the source text notes this is historically linked to recurrent unexplained pancreatitis.
Which makes sense.
Because normally the duct of Wirsung handles the heavy lifting, emptying through the major duodenal papilla, which is a wide, robust valve. But in divisum, the duct of Santorini has to push all that fluid through the minor duodenal papilla, which is functionally a much smaller, less elastic opening.
Okay, but hang on. If 10 to 15% of the population has pancreas divisum, we know for an absolute fact that millions of these people go their entire lives completely asymptomatic, right?
Absolutely. Many never know they have it.
They never develop recurrent pancreatitis. So why does the minor duct of Santorini handle the drainage load perfectly for some, but then fail so catastrophically, causing autodigestion for others?
Well, if you look at the physics of fluid dynamics, specifically Poiseuille's law flow rate, is profoundly dependent on the radius of the tube. It's not just about the fact that the duct of Santorini is smaller overall. It is about the microscopic muscular sphincter at the very end of it, the sphincter of Helle.
The sphincter of Helle, okay.
For the asymptomatic majority with divisum, that sphincter has just enough elasticity and luminal diameter to handle the flow of the exocrine juice. It is a really tight squeeze, but the fluid dynamics hold up.
So it sort of functions like a pressure release valve that is just barely keeping up with the factory's output?
Exactly. just barely.
Yeah.
But for the symptomatic patients, there is a degree of stenosis, so a microscopic narrowing or fibrosis or rigidity of that minor sphincter.
And that's where the problem starts.
Right. When you combine a stenotic sphincter with a high-volume organ actively synthesizing liters of thick, enzyme-rich fluid, you create an immediate back pressure phenomenon inside the ductal system.
It is the equivalent of clamping your hand over a fire hose while the hydrant is fully open?
That is exactly what's happening. The back pressure causes the digestive enzymes to pool and stagnate deep inside the microscopic pancreatic acini. And these are not benign fluids. They contain zymogens, which are inactive precursors to digestive enzymes.
And normally these zymogens don't become active until they safely reach duodenum, right?
Correct. But when they stagnate and pool under high pressure inside the pancreas, the internal cellular environment becomes stressed. The zymogen granules can abnormally fuse with intracellular lysosomes.
Oh, that's not good.
No, because the lysosomes contain an enzyme called cathepsin B, and cathepsin B acts like a biological match. It cleaves the inactive trypsinogen into active trypsin right there inside the pancreatic cell.
Wow. And trypsin is the master switch. Once trypsin is activated inside the cell, it activates all the other digestive enzymes, right? Like the lipases, the elastases, the proteases.
Yes, and suddenly the pancreas is actively, aggressively digesting its own tissue. That is the cellular genesis of acute pancreatitis in a Devisum patient.
Which is why, diagnostically, you cannot just order a standard CT scan if a patient comes in with mysterious recurrent central abdominal pain.
Right, a CT might miss it entirely. You need advanced fluid-sensitive imaging.
So as a clinician, you are looking for an MRCP, right? Magnetic resonance cholangiopancreatography?
Exactly. An MRCP utilizes heavily T2-weighted MRI sequences. So static fluid, like the backed-up pancreatic juice and the duct of Santorini, glows bright white against the dark background of the solid organs.
Oh, that's so cool. So it allows you to trace the exact embryological failure of the ducts without exposing the patient to radiation or using invasive scopes.
It's a beautiful imaging modality. And if the MRCP confirms symptomatic Devisum with a stenotic minor papilla, the management often involves an ERCP, an endoscopic retrograde cholangiopancreatography.
Right. Where the gastroenterologist physically threads a scope down into the duodenum, finds that tiny minor papilla, and performs a sphincterotomy.
Basically cutting the muscle to widen the opening. Or they might place a microscopic stent to permanently prop the door open and relieve the pressure.
You are literally surgically altering the fluid dynamics to save the organ from itself.
You have to.
Okay, so now let's look at another anomaly that happens much earlier in the timeline. During that 6-week rotation phase, the annular pancreas.
Oh, this is a fascinating one.
Because instead of the ventral bud migrating smoothly as a single unit, the source text indicates the rotation can be incomplete or bifurcated. The ventral bud is actually bilobed.
Yep.
And if one lobe migrates normally to the right while the other lobe migrates to the left or stays tethered, it ends up leaving a complete constricting ring of pancreatic tissue totally encircling the descending or second part of the duodenum.
It's a profound structural error. And clinically, the first diagnostic tip-off for an annular pancreas often happens before the baby is even born. Well, the maternal fetal medicine specialist performing a routine ultrasound will frequently note maternal polyhydramnios, which is an excess of amniotic fluid in the womb.
Ah, because the mechanics of fetal fluid regulation are disrupted.
Exactly. In a normal pregnancy, the fetus is constantly swallowing amniotic fluid. It passes through the stomach, the duodenum, and then gets absorbed in the small bowel, which helps regulate the fluid volume in the sac.
But with an annular pancreas, that ring of tissue is physically choking off the duodenum. It's an extrinsic compression.
Right, so the swallowed fluid hits that roadblock. It cannot pass into the fetal gut for absorption, and therefore it backs up, leading to a massive accumulation of fluid in the amniotic sac.
And when that child is born, they will quickly present with feeding intolerance, bilious vomiting, and signs of complete or partial bowel obstruction.
Yes, and structurally, an annular pancreas rarely occurs in a developmental vacuum. Because the embryological signals during weeks 4 through 6 are so deeply intertwined with the formation of the entire midline, this anomaly is heavily associated with major genetic and developmental syndromes.
Yeah, the text specifically links it to autosomal recessive mutations and trisomy 21, or Down syndrome.
The association with trisomy 21 is critical for any pediatric surgeon to remember. The genetic overexpression of certain cell adhesion molecules in Down syndrome is thought to disrupt the normal migratory pathways of the ventral bud, We also see high rates of the Vactral association.
Oh, let's break down Vactral for the listeners, because it beautifully illustrates how interconnected early embryonic mesoderm and endoderm development truly is.
It really does.
So Vactral stands for vertebral anomalies, anal atresia, cardiac defects, tracheoesophageal fistulas, renal anomalies, and limb abnormalities.
Right. So if you have a newborn presenting with, say, a duplicated thumb or an imperforate anus, you have to possess a high index of suspicion that their internal foregut rotation, like the pancreatic migration, might also be severely deranged.
It forces the clinician to look at the patient as a whole developmental system, rather than just treating a single isolated symptom.
Absolutely. Now, when it comes to the surgical management of an annular pancreas, this is a classic FRCS exam trap.
Oh, I can see why. You have a ring of pancreatic tissue strangling the duodenum. The intuitive mechanical thought is just take a scalpel and cut the constricting ring of tissue to free the bowel.
Right. But doing that would be catastrophic.
A completely fatal error.
Yes. You must remember that this anomalous ring of pancreatic tissue is not just a fibrous band. It is fully functional, highly vascularized glandular parenchyma. It is packed with microscopic ducts actively secreting those potent proteolytic enzymes we just discussed.
Right, so if you cut into the substance of the annular pancreas, you will almost certainly cause a massive postoperative pancreatic fistula.
Exactly.
Yeah.
The caustic enzymes will leak directly into the peritoneal cavity, digesting the surrounding surgical planes and major blood vessels.
So how do you fix the obstruction if you can't remove the roadblock?
You bypass it entirely. The standard surgical management is a duodenojejunectomy.
A duodenojejunectomy.
Okay. You take a healthy loop of the jejunum, which is the next segment of the small intestine, you bring it up, and you stitch it directly to the dilated portion of the duodenum that sits just above the pancreatic ring.
Ah. You create a detour, allowing the stomach contents to bypass the strangled segment completely, leaving the dangerous pancreatic tissue totally undisturbed.
Right. Bypass the traffic jam. Never try to tear up the road itself when the road is made of highly reactive chemical explosives.
That is such a vivid rule of thumb for surgeons.
It saves lives.
Okay, that leads us to another fascinating developmental error mentioned in the text: ectopic pancreatic tissue. The source notes that in about 3 to 5% of the general population, fully functional pancreatic acinar cells and ductal tissue end up growing where they have no business being.
Yeah, most commonly embedded within the muscular walls of the stomach, or the jejunum of the small intestine.
How does that even happen?
Well, these are essentially rogue clusters of cells. They separated from the main endodermal buds during that chaotic embryological rotation we talked about. They migrate into the surrounding submucosa, or the muscularis propria of the developing gut tube.
And most of the time, they are discovered incidentally during an endoscopy for an unrelated issue, right?
Usually, yes. They have a very characteristic umbilicated or dimpled appearance. It's like a small, yellowish nodule with a central depression, which is actually a tiny rudimentary duct trying to drain the ectopic secretions.
That is wild. But while they are often asymptomatic, their physical presence in the wall of the bowel can initiate a severe mechanical emergency. The text highlights that these ectopic nodules can act as a dangerous lead point for an intussusception.
Right, and intussusception is a terrifying mechanical event.
Walk us through that.
Imagine the small intestine as a long, flexible telescope. The gut naturally moves food forward through rhythmic muscular contractions called peristalsis. When you have a solid nodule of ectopic pancreatic tissue bulging into the lumen of the intestine, the peristaltic wave treats that nodule as a bolus of food.
Oh no, so the gut aggressively clamps down on it and tries to push it forward.
Exactly. But because the nodule is physically tethered to the intestinal wall, the gut ends up dragging itself forward.
It pulls the segment of intestine containing the nodule inside out, telescoping it directly into the adjacent downstream segment of the bowel.
Yes. This causes an immediate catastrophic obstruction.
Yeah.
And more importantly, as the bowel telescopes inside itself, it drags its mesenteric blood supply along with it.
Right, the vessels get caught in the fold.
The blood vessels become tightly compressed, leading to venous engorgement, arterial ischemia, and rapid necrosis of the bowel wall if it's not surgically corrected. An incidental 3-millimeter cluster of ectopic pancreatic cells can result in the loss of 3 feet of necrotic intestine.
That is devastating, just from a tiny rogue cluster of cells.
It really highlights the stakes.
So we've talked about parts in the wrong place. We also have to look at the opposite end of the spectrum, agenesis, where specific parts of the organ or even the entire gland simply fail to develop.
Right.
The source material notes that partial or dorsal agenesis is intrinsically linked to early onset diabetes mellitus. And mechanically, based on what we established about the buds, that makes perfect sense.
Yes, because the dorsal bud is responsible for forming the body and the tail of the pancreas. And, crucially, the tail of the pancreas contains the highest anatomical concentration of the islets of Langerhans.
Which are the microscopic endocrine clusters that house the insulin-producing beta cells.
Exactly. If a genetic mutation, such as a defect in the PDX1 gene, prevents the dorsal bud from forming, you are structurally missing the vast majority of your insulin factory.
So the patient will present with severe hyperglycemia.
Yes, and they'll require lifelong exogenous insulin, alongside other developmental anomalies like polysplenia, which is the presence of multiple accessory spleens and malabsorption due to the missing exocrine output.
Okay, and the text also details dysgenesis, which is the abnormal or defective cellular development of the gland. And this is deeply tied to complex syndromic associations like Johansen-Blizzard syndrome and Shwachman-Diamond syndrome.
Right, these aren't just mechanical ductal failures. These are fundamental genetic breakdowns at the cellular level.
Right.
If we look closely at Shwachman-Diamond syndrome, for instance, it perfectly illustrates the vulnerability of the exocrine tissue. This is an autosomal recessive disorder, primarily driven by mutations in the SBDS gene, which is essential for normal ribosome biogenesis.
And ribosomes are the cellular machines that manufacture proteins.
Exactly. Remember, the pancreatic acinar cells have one of the highest rates of protein synthesis in the entire human body, constantly churning out massive quantities of digestive enzymes.
So when ribosome assembly is genetically defective,
these highly demanding acinar cells essentially undergo stress-induced apoptosis. They just die off.
and the body replaces that dying functional tissue with fat.
Precisely. You see extensive fatty replacement of the pancreatic parenchyma. The patient presents with profound exocrine insufficiency, chronic diarrhea, failure to thrive, and notably, bone marrow dysfunction like neutropenia.
Because the rapidly dividing stem cells in the marrow are equally dependent on robust ribosome function.
Exactly. It is a dual systemic failure originating from a single microscopic cellular machine.
Wow. Okay, the final congenital anomaly the source text covers in this developmental section is choledochal cysts. Now, technically, these are congenital dilations of the biliary tract, the bile ducts.
Right.
But because of that intimately shared embryological origin near the ventral bud, they frequently present alongside pancreatic anomalies.
The biliary and pancreatic drainage systems are completely structurally linked. A choledochal cyst is a localized cystic dilation of the bile duct. One of the prevailing theories for why they form is the long common channel theory.
Okay, what is that?
In normal anatomy, the bile duct and the pancreatic duct join just millimeters before entering the duodenum. In patients with choledochal cysts, the junction happens abnormally high, creating a long shared duct outside the protection of the sphincter.
Ah, meaning the high-pressure pancreatic enzymes can easily reflux backward, flowing up into the biliary tree.
Exactly. Those caustic pancreatic proteases wash backward into the fragile bile duct walls, stripping the mucosa, weakening the connective tissue, and causing the duct to balloon outward into a massive cyst.
And clinically, these patients present with the classic triad of right upper quadrant abdominal pain, jaundice, and a palpable mass.
Yes. And the text specifically notes they present with elevated direct or conjugated bilirubin, but generally normal transaminases.
And that is a key diagnostic laboratory distinction for our clinical listeners.
It is. Transaminases like AST and ALT are markers of hepatocellular injury. They spike when the liver cells themselves are dying. But direct bilirubin elevates when the liver is functioning perfectly, successfully conjugating the bilirubin, but the physical plumbing carrying that fluid away is blocked.
The cyst creates biliary stasis.
Exactly. The fluid backs up into the liver, and the conjugated bilirubin spills over into the bloodstream, turning the patient's skin and sclera yellow. To diagnose this, a high-resolution ultrasound, followed by a dedicated MRCP to map the exact cyst anatomy, typically categorized by the Todani classification system, is absolutely essential before surgical excision.
The Todani classification, right. Okay, so let's assume the organ survives all of this. It develops normally, it successfully navigates the week 6 rotation, the ducts fuse flawlessly at week 17, and it sets up shop in the adult abdomen.
A best-case scenario.
Right. But where it finally anchors itself creates one of the most terrifying, hazardous anatomical landscapes for any surgeon to navigate. This brings us to topographic anatomy and the true surgical reality of the pancreas.
Welcome to the retroperitoneum.
Right. The text defines the pancreas as a retroperitoneal accessory digestive gland. It lies transversely, stretched horizontally across the posterior abdominal wall, physically crossing over the bodies of the first and second lumbar vertebrae, L1 and L2.
Correct.
If we map the external borders, it is firmly sandwiched between the duodenum on its right side and the hilum of the spleen on its left.
To truly conceptualize this space, you have to think in 3 dimensions. The anterior perineal space of the retroperitoneum is not a wide-open cavern. It is an incredibly dense, crowded compartment.
Oh, dense.
The pancreas is packed in so tightly that it physically takes on the shape of the structures compressing it. Let's start with the head.
Okay, so the head is the enlarged right extremity of the gland, and it is nested tightly inside the C-loop of the second and third parts of the duodenum.
And when we say nested tightly, it is crucial to understand that there is no safe surgical plane between the head of the pancreas and the medial wall of the duodenum.
None at all.
None. They are embryologically and physically fused, sharing an intricate, inseparable microvascular blood supply. You cannot bluntly peel the pancreas off the duodenum.
And what lies directly posterior to the head is even more intimidating. The entire right side of the pancreatic head rests directly, heavily, upon the inferior vena cava, which is the largest vein in the body, returning all blood from the lower extremities, as well as the right renal vein.
Yes. Furthermore, the common bile duct physically courses downward, carving a deep groove into the posterosuperior surface of the pancreatic head.
And in some people, it's actually inside the head, right?
Exactly. In a significant percentage of patients, the bile duct doesn't just sit in a groove. It is completely enveloped, tunneling deep through the actual glandular parenchyma of the pancreas itself before it reaches the intestine.
Which perfectly explains why a patient with an early, tiny adenocarcinoma in the head of the pancreas almost instantly presents with painless jaundice.
Yes, the tumor acts like a vice.
Even a millimeter of growth immediately pinches that embedded bile duct shut, backing the bilirubin up into the system long before the tumor is large enough to cause actual pain. The microscopic anatomy directly dictates the gross clinical presentation.
Precisely. As we move to the left from the head, we enter the neck of the pancreas. The neck is characteristically short, only about 1.5 to 2 centimeters long.
But what it lacks in size, it makes up for in critical vascular relationships.
It does. The neck sits directly anterior to the formation of the portal vein. The superior mesenteric vein comes up from below, the splenic vein comes over from the left, and they merge together directly behind the neck of the pancreas to form the main portal trunk leading to the liver.
Wow. So as a surgeon, if you are performing a Whipple procedure, a pancreaticoduodenectomy, you have to carefully slip your instruments directly behind the neck of the pancreas, right over the top of the portal vein, to create a tunnel before you transect the organ.
Yes, and 1 millimeter too deep, and you tear the portal vein, leading to catastrophic blinding hemorrhage in a matter of seconds. The tunnel behind the neck is often considered the point of no return in a Whipple. Once you safely navigate the neck, we move to the body of the pancreas.
Right. And the body passes transversely, moving upward and to the left, directly crossing over the abdominal aorta and the L2 vertebra.
All right.
And this is where we hit a massive, crucial surgical detail from the Stat Pearl's source text. It explicitly notes that the anterior surface of the pancreatic body is covered with a layer of peritoneum, forming part of the posterior wall of the lesser sac.
Yes.
However, the posterior surface of the body is completely devoid of peritoneum. It is entirely naked.
And that single anatomical sentence is the defining reason why pancreatic cancer is one of the most lethal malignancies in human biology.
Okay, let's completely unpack this for the clinician because this is huge. In the abdominal cavity, the peritoneum is a slippery, serous membrane. It wraps around organs and lines the cavity. In standard surgery, tissue planes that are lined by peritoneum or discrete fascial layers usually provide a natural, relatively vascular plane for dissection. It acts like a biological boundary. You can physically slide surgical instruments between these fascial layers to safely mobilize an organ away from underlying blood vessels.
Exactly. But on the posterior surface of the pancreas, there is no fascial barrier. There is no protective wall.
Nothing.
The naked, glandular pancreatic parenchyma lies in direct, continuous connective tissue contact with the adventitia, the outermost fibrous layer of the great vessels of the abdomen.
So it is directly fused to the anterior surface of the aorta, the origin of the superior mesenteric artery, the left suprarenal gland, and the left renal vessels.
Yes.
I mean, it's like trying to surgically remove a load-bearing wall where the drywall has been glued directly to the primary high-voltage electrical mains of a skyscraper. There is absolutely no safe buffer zone.
That's a very accurate comparison. When a patient develops a primary pancreatic adenocarcinoma in the body of the gland, that lack of a posterior peritoneal boundary means there is absolutely nothing to physically slow the tumor down.
It just spreads instantly.
The cancer cells microscopically invade the shared connective tissue. They quickly, silently wrap themselves entirely around the superior mesenteric artery or the celiac axis.
This is called vascular encasement, right?
Yes, vascular encasement.
Yeah.
And once the tumor intimately encases those major life-sustaining arterial trunks, the cancer is immediately deemed locally advanced and surgically unresectable.
Because you cannot simply resect and replace the entire origin of the SMA without risking massive ischemia to the entire small bowel.
Exactly. The lack of posterior peritoneum grants the cancer early, unimpeded, silent access to the central vascular and neural real estate of the abdomen.
Furthermore, tracking along those major arteries is the celiac nerve plexus. So the cancer cells utilize a process called perineural invasion, physically creeping along the nerve sheaths.
And that is what eventually causes the agonizing, unrelenting back pain seen in late-stage pancreatic cancer.
The anatomy truly is the pathology here. Finally, the body tapers into the tail. And the tail of the pancreas is the only part of the organ that possesses true mobility.
Right. It passes anterior to the left kidney and courses directly within the layers of the splenorenal ligament until it literally touches the hilum of the spleen, coming to rest near the left colic flexure of the colon.
Which means if a trauma surgeon is performing an emergency splenectomy for a ruptured spleen following a car accident, they have to be incredibly meticulous when clamping the splenic vessels at the hilum.
They do. If they accidentally catch the distal tip of the pancreatic tail in the clamp, they will crush the tissue, sever the distal end of the pancreatic duct, and cause a devastating post-operative pancreatic leak.
You can never treat an organ in the abdomen as an isolated island. Every structure is intimately married to its neighbors.
It's all connected.
And speaking of those deeply integrated neighbors, to survive in and regulate this incredibly dense neighborhood, the pancreas taps into multiple redundant power grids. This moves us entirely into the vascular and neural grid of the pancreas.
The plumbing and the wiring.
Right. The source text outlines an arterial supply that is a staggeringly complex dual system. The pancreas refuses to rely on just one source of perfusion. It pulls massive volumes of oxygenated blood from two of the three primary anterior branches of the abdominal aorta, the celiac trunk, and the superior mesenteric artery.
And the sheer volume of blood flow is a direct reflection of its metabolic demands. Let's map the arterial inflow.
Okay, so for the head and the unsynthetic process, the blood supply approaches from both above and below, acting like a giant pincer. From above, you have the gastroduodenal artery, which is a major branch coming off the common hepatic artery from the celiac trunk. The gastroduodenal artery drops down and splits into the anterior and posterior superior pancreaticoduodenal arteries.
And they drape over the top of the pancreatic head.
Then from below, reaching up from the superior mesenteric artery, you have the anterior and posterior inferior pancreaticoduodenal arteries.
And this is where it gets interesting. These superior and inferior vessels meet in the middle, structurally fusing together to form an intricate, redundant arterial network known as the pancreaticoduodenal arcades.
The arcades.
Right. They form complete loops of blood vessels that perfectly supply both the head of the pancreas and the adjacent C-loop of the duodenum.
And returning to our surgical application, this shared arterial arcade is the anatomical reason why a surgeon cannot easily remove just the head of the pancreas without also removing the duodenum.
Exactly. If you attempt a local resection of a tumor in the pancreatic head, you are forced to ligate and destroy those arcades. The moment you do, you completely strip the duodenum of its blood supply, and the bowel wall will become ischemic and necrose.
They are vascularly bound together for life. To remove one, you must remove both.
That is the head. But the body and the tail run on an entirely separate circuit.
Right. Their arterial supply shifts completely away from the arcades and relies on the splenic artery. And the splenic artery originates from the celiac trunk and takes this incredibly tortuous, winding, almost serpentine path along the entire superior border of the pancreatic body and tail.
And the tortuosity is another spatial accommodation.
Like the embryological rotation.
Exactly. The splenic artery lies posterior to the stomach. As the stomach fills with a massive meal and dramatically distends, the splenic artery needs slack to stretch and accommodate that expansion without snapping or kinking.
That is brilliant design.
It is. As it snakes along the top of the pancreas, it drops down numerous, highly specific vertical branches: the dorsal pancreatic artery, the great pancreatic artery, and the caudal pancreatic artery, directly into the glandular tissue.
So the inflow is highly pressurized and redundant. But the venous drainage, how the blood leaves the pancreas, is where the system reveals its true physiological genius. The venous drainage is also region-specific.
Yes. The head of the pancreas drains its deoxygenated blood into the superior mesenteric vein. The body and the tail drain into the splenic vein.
And as we established when discussing the neck of the pancreas, the superior mesenteric vein and the splenic vein physically converge right behind the pancreatic neck to form the main portal vein.
Now, why is this venous routing so crucial? If you are a medical student, you might look at this and wonder why the pancreas doesn't just drain its deoxygenated blood directly into the nearby inferior vena cava.
Right, sending it straight back to the heart and lungs like the kidneys or the lower limbs do. Why route the venous return exclusively into the portal system?
This is perhaps one of the most elegant examples of form following metabolic function in human physiology. We have to think about what is actually inside that venous blood.
Okay, what's in it?
The pancreas is an endocrine organ. It is dumping massive quantities of hormones, specifically insulin and glucagon, which regulate total body blood sugar directly into its venous capillaries. If the pancreas drained into the systemic venous system via the inferior vena cava, that highly concentrated insulin would travel to the right heart, go through the massive pulmonary circulation of the lungs, enter the left heart, and then be pumped out to the entire peripheral body.
Oh, I see. It would be massively diluted by the time it circulated.
Exactly. The skeletal muscles and fat tissue would absorb the majority of the insulin, while the liver, which is the primary metabolic regulator and glucose storage facility of the entire human body, would receive a delayed, highly diluted signal.
But by routing the venous drainage from the pancreas directly into the formation of the portal vein, the pancreas guarantees a first-pass effect. The portal vein carries that venous blood straight into the liver first.
The pancreas is effectively hardwiring its raw metabolic data directly to the liver's mainframe.
That is breathtaking.
The liver receives the absolute highest, most concentrated bolus of insulin immediately after a meal. This massive localized concentration gradient is what signals the liver hepatocytes to rapidly shut down internal glucose production, gluconeogenesis, and begin absorbing and storing the incoming dietary glucose as glycogen.
The venous architecture is entirely designed to give the liver exclusive first-pass access to pancreatic metabolic commands.
Beautifully said.
To complete the grid, we have to look at the innervation. The source text notes that the pancreas contains a rich intrinsic nerve plexus. The parasympathetic fibers arrive from the posterior vagal trunk.
And these act as secretomotors. When you anticipate a meal, the vagus nerve releases acetylcholine, structurally priming the pancreatic cells to synthesize enzymes.
Right, and this vagal tone is then powerfully amplified by duodenal hormones, specifically cholecystokinin, or CCK, and secretin, which are released into the blood when acidic, fat-rich gastric contents suddenly enter the duodenum.
So the parasympathetic system drives the manufacturing and the output. Conversely, the sympathetic nervous system fibers arrive via the splanchnic nerves, specifically originating from the T6 through T10 thoracic spinal segments, and they synapse in the celiac plexus.
And the sympathetic system is heavily involved in the transmission of pain, which perfectly explains the clinical presentation of pancreatic pain.
It does.
Because the afferent pain fibers travel back up through the T6 to T10 splanchnic nerves, a patient suffering from acute pancreatitis or advanced pancreatic cancer doesn't just feel pain in their stomach.
No.
The pain is referred along those specific thoracic dermatomes, resulting in an agonizing, band-like pain that typically radiates directly from the central upper abdomen straight through to the middle of the back.
The neural wiring maps the exact location of the patient's suffering.
And all of this massive, redundant vascular infrastructure, this complex neural wiring, and this hazardous retroperitoneal positioning exists for one singular purpose. To fuel a microscopic cellular factory that produces two completely different life-sustaining product lines, which takes us down to the cellular level, exploring the microscopic architecture and dual function of the gland.
The pancreas is functionally two completely different organs living under the same roof.
Yeah, the Stat Pearl's text explicitly breaks this down. Roughly 80% to 85% of the total pancreatic tissue mass is entirely dedicated to the exocrine function. This heavy-duty exocrine tissue is made up of millions of microscopic structures called pancreatic acini, which are berry-like clusters formed by individual, highly specialized pyramidal acinar cells.
And if you look at an acinar cell under an electron microscope, its physical architecture is a perfect reflection of its biochemical job. It is a highly polarized cell, meaning the top and the bottom have completely different structures and functions.
Let's map the cell for the listener. The basal region of the pyramidal cell, the wide bottom part that sits closest to the surrounding capillary blood supply houses, the nucleus, and a truly massive, densely packed network of rough endoplasmic reticulum.
The rough endoplasmic reticulum is studded with ribosomes. This basal region is the manufacturing floor. It is actively pulling amino acids directly from the bloodstream and utilizing them to synthesize massive, complex protein chains, the digestive enzymes.
Once synthesized, these raw proteins are shuttled up to the Golgi complex, where they are meticulously folded, packaged, and moved to the apical region, the narrow top of the cell that physically points inward toward the central lumen of the duct.
Here, they are safely stored inside tight vesicles called zymogen granules.
And the concept of the zymogen is critical here, right?
Absolutely critical. Zymogens are biologically inactive precursors. The cell has gone through immense metabolic effort to build these proteolytic enzymes like trypsinogen and chymotrypsinogen, but it deliberately leaves them in a chemically locked state.
They have to be inactive.
Yes. If they were synthesized in their fully active tissue-destroying form, they would instantly digest the very cell that just manufactured them.
They are essentially highly explosive biological munitions that have not yet been armed.
That's right. And waiting on the basolateral membrane of these acinar cells, the side facing the blood, are multiple specific receptors for the triggers we mentioned earlier: secretin, CCK, and acetylcholine.
So when a fatty acidic meal drops out of the stomach and enters the duodenum, the duodenal lining immediately releases CCK and secretin into the bloodstream.
Exactly. These hormones rush to the pancreas, bind to the basolateral receptors of the acinar cells, and initiate a massive intracellular calcium spike.
That calcium spike is the final signal. It triggers exocytosis. The zymogen granules fuse with the apical membrane and forcefully vomit their massive inactive enzyme payloads directly into the ductal lumen.
At the same time, the cells lining the ducts themselves, the ductal epithelial cells, highly stimulated by the hormone secretin, begin actively pumping out vast quantities of water and bicarbonate ions.
Driven by a specific channel called the CFTR chloride channel, right?
Yes. This creates a high-pressure, highly alkaline fluid wave that sweeps the zymogens out of the tiny intercalated ducts into the main duct of Wirsung and washes them down toward the duodenum.
And when this massive wave of fluid and zymogens finally reaches the end of the line, it encounters the sphincter of Oddi.
The blast door.
This is a complex collar of smooth muscle situated at the hepatopancreatic ampulla, the exact junction where the pancreatic duct and the common bile duct meet the wall of the duodenum.
The sphincter of Oddi has a dual role. Under the influence of CCK, it dynamically relaxes, allowing the pressurized wave of bile and pancreatic juice to blast into the descending duodenum to mix with the food.
But between meals, it firmly contracts. It maintains ductal pressure and, crucially, acts as a physical blast door, preventing the heavily contaminated bacteria-rich contents of the duodenum from ever washing backward up into the sterile pancreatic ductal tree.
And it is only when the inactive zymogens safely pass the sphincter of Oddi and enter the lumen of the duodenum that they encounter a specific brush border enzyme called enterokinase.
Enterokinase is the master key.
It is. It chemically cleaves the inactive trypsinogen, turning it into active trypsin. Trypsin then rapidly cleaves and arms all the other zymogens, initiating explosive, highly efficient chemical digestion of the meal, safely within the lumen of the bowel.
That is the exocrine side. High-volume, heavy-duty manufacturing. But interspersed throughout this massive exocrine sea are tiny, highly vascularized islands of tissue dedicated entirely to the endocrine function, the islets of Langerhans.
They make up only 1% to 2% of the gland's total mass, but they completely regulate the body's energy usage.
Amazing.
And the endocrine system operates on an entirely different set of rules. These cellular clusters completely bypass the ductal plumbing system. They have zero connection to the ducts.
Instead, they're intimately entwined with a dense, highly fenestrated capillary network. They secrete their products directly into the bloodstream.
Right, and the text highlights 4 distinct endocrine cell types within the islets, and their spatial arrangement is fascinating.
In the cord of the islet, you have the B cells, or beta cells, which synthesize and release insulin to lower blood sugar and drive glucose into peripheral tissues.
Yes. Surrounding the core, acting almost like a mantle, are the A cells, or alpha cells, which secrete glucagon to mobilize glycogen stores and raise blood sugar when you are fasting.
You also have the D cells, or delta cells, which synthesize somatostatin. Somatostatin is the master inhibitory hormone. It acts locally, or via paracrine signaling, to put the brakes on both insulin and glucagon secretion, keeping the system tightly balanced.
Finally, there are the F cells, which generate pancreatic polypeptide, regulating both exocrine and endocrine secretory tone.
And the cellular layout dictates the feedback loop, doesn't it?
It does. The blood flow in an islet moves from the central core outward to the mantle. This means the highly concentrated insulin from the core beta cells washes directly over the alpha cells on its way out into the venous system.
Oh, so that high local concentration of insulin physically binds to the alpha cells and immediately suppresses their release of glucagon. The organ uses its own microvascular flow to inhibit competing hormones.
It is a breathtakingly elegant system of localized autoregulation.
But there is one specific enigmatic cell type mentioned in the Stat Pearls text that seems to bridge the gap between structural integrity and pathological destruction: the stellate cell.
The stellate cell.
The text describes pancreatic stellate cells as structures that, under chronic conditions, drive profound inflammation and fibrosis. Why do these cells exist if their primary role seems to be laying down restrictive scar tissue?
Pancreatic stellate cells are the subject of intense PhD-level molecular research right now. Because in a healthy, uninjured pancreas, stellate cells are not destructive at all. They exist in a quiescent or sleeping state.
Okay, so what do they do when they're asleep?
They live in the periacinar spaces, and their primary physiological job is to quietly maintain the normal, delicate extracellular matrix, the structural scaffolding that holds the delicate acini and capillaries together.
Okay.
Intriguingly, in their quiescent state, they are also the primary storage site for vitamin A in the pancreas, holding it in large, cytoplasmic lipid droplets.
But they don't stay asleep forever.
No, they don't. When the pancreas suffers repetitive chemical, toxic, or inflammatory injury, for example, from years of chronic heavy alcohol abuse, or recurrent ductal obstruction from microgallstones, the stressed and dying acinar cells begin releasing distress signals.
They release powerful inflammatory cytokines, specifically transforming growth factor beta, or TGF-beta, and platelet-derived growth factor, PDGF.
And these cytokines act as an alarm bell for the stellate cells.
They activate the stellate cells.
The transformation is profound. The activated stellate cell suddenly dumps its stored vitamin A droplets. It completely changes its physical shape, essentially transforming into a myofibroblast, a hybrid between a structural cell and a contracting muscle cell.
It begins expressing alpha-smooth muscle actin, allowing it to physically contract, and it starts rapidly proliferating.
And most importantly, it starts manufacturing extracellular matrix.
It begins aggressively secreting massive amounts of type I collagen and fibronectin into the surrounding tissue.
Physiologically, this is intended to be a tissue repair mechanism. The stellate cell is frantically trying to wall off the site of the toxic injury and heal the wound.
It is the biological equivalent of a construction crew pouring concrete over a ruptured chemical line to contain a spill.
Precisely. But the tragedy of chronic pancreatitis is that the toxic insult, the alcohol, the strictures, never stops.
The inflammatory cytokine signal never turns off.
Right. The stellate cells are caught in a permanent state of hyperactivity. The repair mechanism becomes destructive. They lay down so much dense restrictive collagen that they physically choke out the healthy, functioning acinar cells and the delicate islet capillaries.
So the soft glandular organ is progressively replaced by hard, pale, fibrotic scar tissue.
The builders lose their blueprints and simply won't stop pouring concrete until the entire organ is suffocated.
This cellular cascade perfectly sets up the final section of our deep dive: clinical pathology and surgical significance. Because when this delicate cellular balance fails, whether from ductal blockages, genetic mutations, external toxins, or stellate cell hyperactivity, the pancreas transforms from a life-giving metabolic regulator into a lethal internal threat.
And nothing demonstrates that lethal threat more acutely than a full pancreatic perforation with self-digestion.
The text outlines this grim scenario. If the integrity of the ductal tree or the capsule is breached, say, from a severe blunt force trauma to the abdomen in an automobile accident where the pancreas is physically crushed against the L2 vertebra,
The pressurized pancreatic juice heavily laden with fully activated amylase, lipase, and proteases, forcefully leaks directly into the retroperitoneal space and the greater abdominal cavity.
Because these enzymes are now free-floating in the wrong anatomical compartment, they immediately begin acting on whatever tissue they touch.
The lipase rapidly hydrolyzes the surrounding retroperitoneal fat, a process known as fat saponification, turning the fat into a hard, chalky, soap-like substance.
And the proteases violently digest the delicate fascial planes and aggressively erode the walls of adjacent blood vessels, leading to massive pooling retroperitoneal hemorrhage.
It is functionally a severe chemical burn occurring deep inside the patient's abdomen.
The source material notes that aggressive surgical removal, a partial or total pancreatectomy alongside massive fluid resuscitation and surgical washout may be required to physically stop the source of the caustic leak and save the patient's life.
But if a total pancreatectomy is performed, the physiological consequences are absolute.
You are forced to trade an acute, highly lethal surgical emergency for a profound, complex, lifelong chronic disease state.
Right. If you remove the organ, the patient is instantly thrown into brittle, surgically induced type 1 diabetes mellitus. They have zero endogenous insulin or glucagon production, requiring highly intensive lifelong blood glucose monitoring and exogenous insulin administration.
Furthermore, they suffer immediate absolute exocrine insufficiency. Without the acinar factory, they cannot digest fats or complex proteins. They will suffer severe malabsorption, steatorrhea, and malnutrition unless they take massive doses of synthetic pancreatic enzyme replacement therapy orally with every single meal or snack for the rest of their lives.
It highlights just how irreplaceable the organ truly is.
Moving slightly downstream from trauma, we have pancreatitis, the acute or chronic inflammation of the gland itself. The text lists the two overwhelming classic causes: recurrent gallstones and chronic alcohol abuse.
We touched on how micro gallstones dropping from the gallbladder can physically impact and lodge at the narrow ampulla of Vater, blocking the shared outflow tract and causing high-pressure bile and pancreatic juice to back up into the fragile Ischini.
And we discussed how alcohol's toxic metabolic byproducts, specifically fatty acid acyl esters, physically destabilize the lysosomal membranes inside the acinar cells, causing them to prematurely rupture and activate the trypsinogen.
But the Stat Pearls text also lists some truly surprising esoteric triggers for acute pancreatitis that a PhD or FRCS candidate must commit to memory.
Yeah. Measles, mumps, alpha-1 antitrypsin deficiency, certain medications like thiazide diuretics or azathioprine, and notably, scorpion stings.
The inclusion of scorpion venom is a brilliant illustration of the pharmacology of the acinar cell.
Walk us through that, because that is so wild.
Specifically, the venom of the Titius trinitanus scorpion, the indigenous of Trinidad, contains potent neurotoxins that bind directly to voltage-gated sodium channels in the autonomic nervous system.
Okay.
This causes a massive, uncontrolled systemic release of acetylcholine from the parasympathetic vagal nerve endings.
And as we mapped out earlier, acetylcholine is one of the primary triggers binding to the basolateral receptors of the acinar cells to initiate exocytosis.
Exactly. The scorpion venom artificially hyperstimulates the entire pancreatic exocrine factory to aggressively discharge all of its stored zymogen granules simultaneously, overwhelming the ductal clearance mechanisms and triggering massive explosive autodigestion of the gland.
It effectively hotwires the factory's control panel.
It really does.
Whether caused by a stone, alcohol, or venom, the clinical symptoms of acute pancreatitis are unmistakable. A sudden onset of severe, unrelenting, sharp central epigastric pain that classically bores straight through to the back, driven by that T6 to T10 splanchnic nerve irritation we discussed.
And if the swelling in the head of the pancreas is severe enough to pinch the bile duct, the patient will present with dark urine, alcoholic pale stools, and scleral icterus, or jaundice.
But the most insidious, devastating pathology on the list is pancreatic cancer, specifically ductal adenocarcinoma.
Yes.
The text gives a median age of diagnosis at 71 years old. It remains one of the most notoriously difficult malignancies to treat in modern medicine, and tragically, it is most often found at an advanced, unresectable stage.
The risk factors listed include heavy smoking, chronic obesity, long-standing diabetes, and specific inherited genetic mutations, notably MEN1, which is multiple endocrine neoplasia type 1, and HNPCC, or Lynch syndrome.
To understand the lethality, you have to look at the cellular genetics. Pancreatic adenocarcinoma is overwhelmingly driven by an early, fundamental activating mutation in the KRAS oncogene, followed closely by the loss of critical tumor suppressor genes like CDKN2A, TP53, and SMAD4.
This genetic cascade allows the ductal epithelial cells to proliferate wildly, ignoring all signals for apoptosis.
And finally, the text touches extensively on diabetes mellitus, the absolute failure of the endocrine islet system. It breaks down the two primary phenotypes. Type 1 is characterized as an autoimmune destruction of the B cells.
Usually presenting in childhood or adolescence.
Right. The patient's own cytotoxic CD8 positive T cells fail to recognize the beta cells as self and systematically infiltrate and destroy the islets, leading to an absolute permanent deficiency of insulin.
The factory is selectively burned down by the immune system.
Conversely, type 2 diabetes mellitus, which represents the vast majority of cases globally, is a completely different mechanism. It is driven primarily by peripheral insulin resistance.
The peripheral tissues, the muscles, and the fats stop responding to the insulin signal. The pancreas frantically tries to compensate by hypersecreting more and more insulin, leading to eventual beta cell exhaustion and impaired secretion.
The text notes the initial management involves intensive diet modifications, physical activity, and oral medications, specifically highlighting the biguanide class, such as metformin.
And bringing it full circle back to the liver, metformin doesn't force the pancreas to make more insulin. Instead, it activates the AMPK pathway inside the liver, drastically reducing the liver's abnormal, unchecked output of endogenous glucose, thereby taking the immense metabolic pressure off the failing, exhausted pancreatic beta cells.
As we look at this profound list of pathologies, from the explosive chemical self-digestion of acute pancreatitis to the silent, suffocating spread of ductal adenocarcinoma, it forces a fundamental, almost philosophical question about the anatomy itself. Given how brutally destructive pancreatic enzymes are when they leak, and how vital the endocrine hormones are for daily survival, why didn't human evolution provide the pancreas with a thick, impenetrable, highly fibrous protective capsule like it did for the liver or the kidney?
That's a great question.
A tough, fibrous capsule would theoretically contain the chemical damage of pancreatitis and physically act as a solid barrier to stop cancer from invading the retroperitoneum.
It is a phenomenal question about the architectural trade-offs in human development. The liver has Glisson's capsule, the kidney has Girota's fascia, and a tough renal capsule. But you have to return to our embryological blueprint.
Right, those buds.
The pancreas did not develop as a massive, standalone, solid organ in a wide-open abdominal space. It was formed by two fragile endodermal buds desperately squishing together and elongating within the cramped, ever-shifting dorsal mesentery, constantly adjusting to the violent, massive rotations of the stomach and duodenum.
It simply grew into the available crevices between the major retroperitoneal vessels.
It is essentially an organ that grew in the negative space between other structures.
That makes so much sense.
Furthermore, a highly rigid, fibrous capsule fundamentally restricts volumetric expansion. The pancreas is an organ that constantly dramatically fluctuates in volume, blood flow, and interstitial fluid pressure based entirely on the massive secretory demands of every single meal.
Oh. So a tough, non-elastic capsule would lead to incredibly high intracellular pressures during peak digestion.
Exactly. It would essentially be creating a compartment syndrome of the pancreas multiple times a day.
But the lack of that tough capsule is undeniably its greatest clinical vulnerability.
It is the Achilles heel. When acute inflammation hits, there is absolutely no physical firewall. The highly caustic, enzyme-rich fluid simply weeps directly out of the gland, tracking rapidly down the unprotected retroperitoneal fascial planes to bathe the colon, the spleen, and the kidneys in inflammatory toxins.
And when cancer arises, as we mapped out with the naked peritoneum-free posterior surface, there is no fortress wall for the tumor to breach. The malignant cells are instantly, intimately in contact with the major neurovascular bundles of the central abdomen.
It leaves the organ entirely exposed.
As we wrap up this deep dive, you really have to view the pancreas as the ultimate hidden puppet master of human physiology. You never physically feel it expanding like your lungs as you breathe. You never feel it beating forcefully in your chest like your heart.
Right.
Yet its exact microscopic chemical calibrations dictate every single drop of your metabolic energy. And its chaotic, perilous anatomical layout creates some of the most complex, high-stakes surgical challenges in all of modern medicine. It demands absolute reverence from anyone holding a scalpel in the retroperitoneum.
You must intimately understand the 4-week embryological blueprints to accurately anticipate the devastating ductal variations, and you must deeply respect the dense vascular and neural webs that keep the organ functioning.
And that leads me to a final, highly provocative thought to leave you, our listener, with as you study these pathways. We spent significant time discussing the biology of those stellate cells.
The pancreas in our builders.
Right. The builders that wake up, lose their vitamin A, transform into myofibroblasts, and endlessly pour dense, restricting collagen concrete, building fibrotic scar tissue around the organ. In pancreatic ductal adenocarcinoma, these stellate cells are pathologically hijacked by the cancer cells.
Yes, the tumor physically forces the stellate cells to build a massive, almost impenetrable fortress of desmoplastic scar tissue, completely encapsulating the tumor microenvironment.
A fortress that is notably hypovascular, meaning it has incredibly poor blood supply.
Exactly. And because the scar tissue is so dense and the blood vessels are physically compressed by the collagen, standard life-saving intravenous chemotherapy literally cannot reach the actual malignant cancer cells.
The chemotherapy molecules physically bounce off the walls of the desmoplastic stroma. So if you are a PhD researcher in a lab or a future surgical oncologist thinking about the very next frontier of survival rates, could the true future of treating pancreatic adenocarcinoma lie not in developing more toxic drugs to attack the tumor itself, but in biologically reprogramming those hijacked stellate cells?
Could we utilize vitamin D receptor ligands or specialized genetic therapies to force the stellate cells to drop their tools, revert to their quiescent state, stop pouring concrete, and actively tear down the collagen fortress walls so the chemotherapy can finally get inside?
Manipulating the tumor microenvironment to strip the cancer of its armor? It is a brilliant, entirely necessary avenue for the next generation of targeted oncological therapies.
It really is.
Something vital for you to mull over as you visualize these microscopic pathways and retroperitoneal planes. Keep questioning the anatomy, good luck with your surgical exams and your research, and keep diving deep.